We believe that substantial work has to be done in each of these areas to ensure that HIT benefits all and indeed leaves no community behind. Now, so who are the people who are in danger of being left behind? Clearly, they include the 47 million uninsured individuals in the United States, a number which can only climb in light of the current economic recession. And although the data exists to prove this, I don't think we need researchers to tell us that uninsured individuals are more likely to go without needed care and less likely to have a usual source of care. In reality, the usual source of care for many uninsured is an emergency room, where electronic health records are rarely available. Now, by definition, persons living in urban and rural health professional shortage areas are underserved. I was frankly stunned to see the magnitude of need that's documented by HRSA. Using a population to practitioner ratio of 2,000 to 1, 65 million people are living in primary care health professional shortage areas. 65 million people. And in fact, to meet the need, an additional 16,585 primary care providers would be needed. Now, when you start looking at mental health HPSAs and dental HPSAs, the situation is equally alarming. So there is a lot of need out there, and there are a lot of underserved. Now, we also know that communities of color represent the underserved. What we may not always be aware is that in 2008, when estimates were made, 34% of the population are from the 5 major racial and ethnic groups: African Americans, Asian Americans, American Indian, Alaska Native, Latino Hispanics, and Native Hawaiians and other Pacific Islanders. That equates to 103 million people. By the year 2050, it's estimated that 54% of the population will be from those groups. So you cannot talk about the underserved without talking about communities of color. Now, obviously, not all people who are of color are underserved, but many are. And if you look at access and quality measures that have been underscored by the Agency for Healthcare Research and Quality, and you know they've been issuing their National Healthcare Quality Report and Healthcare Disparities Report since 2004 every year. What they have demonstrated, and in the current report we find, that for blacks, Asians, American Indians, Alaska Natives, Hispanics, at least 60% in relation to whites are not improving regarding measures of quality care. 60%. The report's authors also make the point that when you, in spite of the fact that social and economic status explains some of the differences, they persist with regard to health insurance availability, health status, and outcomes, and these differences are racially and ethnically related. So we have, when we talk about the underserved, we're clearly talking about communities of color. Our organization is big on definitions, and so because we realize that if you don't know what you're talking about and don't share that understanding, you won't be able to communicate effectively. So others have talked about the safety net, who they are. We can certainly say that communities of color and other underserved populations are disproportionately served by safety net providers. We found a report, had actually overlooked it when it came out, from the Institute of Medicine called America's Health Safety Net, Intact but Endangered. The IOM has set forth a broad and inclusive definition of what a safety net provider is. They say that safety net providers organize and deliver a significant level of health care and other health-related services to underinsured, Medicaid, and other vulnerable populations. Now, that definition clearly encompasses everyone who has spoken today and many, many others who are not at the table. What we often overlook, however, is that private physicians represent the safety net. And that's often neglected in our discussion about safety net providers. The Kellogg Foundation calls them the invisible giant of the nation's health care safety net. NCQA and the California Medical Foundation have released recent reports that show evidence that people of color, Medicaid beneficiaries, and the uninsured are far more likely to seek care from solo and small group practices than any other group. And we also see that a substantial portion, for example, in the state of Michigan, 55% of the Medicaid and uninsured are receiving care from the private physicians. And in other instances, as many as 73% of primary care visits are to these individual solo or small practice physicians. So they are a very critical part of the safety net, which does not often get addressed. Our organization has assessed the high-tech provisions of the ARRA against the backdrop of these data and our organizational values. We've been encouraged by the results of our review, but we do see indications of a growing awareness at the federal level of the need to address the underserved in HIT-related policy. The latest draft of ONC in terms of meaningful use has some positive features. We frankly would prefer a commitment to eliminate health disparities and not just reduce them, but the words reduce health disparities are prominent, and they are stated in the lead health outcomes policy priority. We also were pleased to see that there is a requirement for collection of race, ethnicity, and primary language data in the early years of adoption among meaningful users, and that's an important development, where it allows us to track progress and monitor how things are going. And we also strongly support the patient-centered focus of the current draft definition. We also think that there are some other ARRA provisions that have merit. Clearly, cash incentives for Medicare and Medicaid providers will be helpful in encouraging widespread adoption. We've heard that there are other reasons why they may not be as helpful as we would like. The recognition of the special needs of eligible professionals in health professional shortage areas is important, as is the possibility of exemptions from payment adjustments for providers who are facing unusual challenges. At the same time, our organization has identified some challenges or areas where improvements are needed. And in the time remaining, I'd like to speak to 4 of those issues and our proposed solutions. My colleagues on the panel have talked about the need for inclusion of safety net provisions in HIT initiatives funded by ARRA. My slide here is not quite accurate because there is the possibility of eligibility for incentives. But the question is, are there resources necessary so that organizations can take advantage of those incentives? And that is a matter of concern. Now, if a way cannot be found through regulations, legislation, health reform legislation, may be needed to reflect the reality that communities of color and other underserved populations could definitely be further disadvantaged if safety net providers cannot receive some of those resources. Having incentives are not enough, particularly if they're reimbursable, and particularly if there isn't the kind of seed money that allows the structures necessary to make them work. We know that there is a low adoption rates throughout the country, whether we're talking about hospitals, community health centers, or private physicians with regard to HIT. We believe that there has been an absence of reference to the need for significant resources for outreach. Our concern is that there are many, many people, particularly private physicians, who won't know a thing about these incentives, or who will find out about them much too late to even qualify. You will recall that CMS conducted a major outreach campaign on Medicare Part D 2 or 3 years ago. National, comprehensive, extremely well-funded. So well-funded, we discovered that $250 per beneficiary was spent on that campaign. We don't know if we can afford that for the kinds of people we're talking about here. But we certainly believe that there has to be an investment in reaching out and informing organizations and individuals how they can qualify, if they qualify, and what is necessary for them to participate in these initiatives. Now, another factor in low adoption rates is the need for a continuum of technical assistance. We've talked about some of that already. We do need, safety net providers will need additional help such as workflow redesign, workforce development and training, decision support, telemedicine applications, and most importantly, hands-on technical assistance, because this is a very complicated process. So giving the resources to acquire a system without that support is essentially not going to work very well. We also believe strongly that consumers need to be contacted. In a recent study conducted in California, researchers found that 70% of consumers reported that their physicians having HIT is important to them. 70%. Now, we understand there are privacy concerns, confidentiality concerns, but there is a strong sense of support among consumers for this technology. We also believe that engaging consumers is a key strategy to drive adoption by providers. If consumers come into the office and request, why don't you have any EHR? That may very well be an incentive for the provider to move in that direction. But if they don't know about this, they will not be able to serve that role. And so we consider a campaign to inform both providers and consumers of available incentives and possible penalties is just as urgent as CMS's efforts earlier about prescription drug coverage. We also think that there are solutions available in the form of grants to community-based organizations who can conduct those campaigns in culturally and linguistically appropriate ways. We also think that the regional extension centers could be tasked to communicate and collaborate with community-based organizations for that purpose. The ultimate test of effectiveness and other recommendations in terms of participation is, are these safety net providers participating? We really think that ONC should monitor the number and percentages of safety net providers in hospitals once the program is underway to see if they are indeed participating in appropriate numbers relative to their capacity to participate and their potential eligibility. If we don't know that, then we may in 2014 look up to find that we have the same disparities in terms of participation that we currently see. Tomorrow, our organization will present to the HIT Policy Committee summary comments and a revised set of 29 recommendations on meaningful use. And what you have in your package is our first version of those recommendations. I'll be happy to share the revised version after we share that tomorrow. But we do think that there are changes that are still needed, even though there's movement in the right direction. We urge the National eHealth collaboration and the viewing and listening audience to join us in ensuring that all communities benefit from HIT. This is, in our view, a transformative moment, and the tools to achieve health and healthcare quality, parity, and equity are truly within our reach. Our organizations have much in common, and we look forward to working with you in the weeks and months ahead. And we certainly welcome the opportunity to communicate with you in the future. Thank you.